Let's consider the case of a 28-year-old female presenting to the neurology clinic with complaints of right lower limb weakness, which is progressive, and visual impairment in the left eye. The symptoms have evolved over the past 6 months with intermittent episodes of neurological disturbances. The approximately 6 months prior to presentation, the patient began experiencing intermittent numbness and tingling sensation in both upper and lower limbs, which was initially mild and transient and self-resolving. She did not seek medical attention at the time, attributing them to fatigue or poor posture. 3 months ago, she experienced sudden episodes of visual loss in the left eye, described as blood vision, that progressed to partial vision loss over a few days, associated with periorbital pain, particularly on eye movements. The symptoms improved gradually over a few weeks, but they did not return to baseline. She was not evaluated during this episode. 1 month prior to presentation, she developed progressive weakness in the right leg, making it difficult to climb stairs or walk long distances. The weakness was not associated with pain but was accompanied by a sense of heaviness and stiffness. She also noticed increased muscle tone and occasional spasms, especially in the morning. On further questioning, she reported episodes of urinary urgency and occasional hesitancy, though she denied of any frank incontinence or retention. She also described fatigue and difficulty in concentrating over the past few weeks. She denied recent infections, trauma, or travel history. There is no significant past medical history or family history of neurological diseases. To understand these symptoms, let us look at multiple sclerosis. So, this disease is an autoimmune demyelinating disorder characterized by distinct episodes of neurological deficits that are separated in time and attributable to patchy white matter lesions that are separated in space. uh, what happens is in a normal nerve, the saltatory conduction maintains a very fast conduction speed, but when due to factors demyelination occurs, this conduction speeds become very slow. This disease has a predominance in female population of with a ratio of 2:1 male to female, and age of 20 to 40 is the most common age for the population suffering from MS. Now, before we move on to MS, let's see some more demyelinating disorders to keep a differential. Now, there are CNS diseases and peripheral nervous diseases. In CNS, we have autoimmune conditions like MS and neuromyelitis optica, nutritional deficiencies like Wernicke's encephalopathy and subacute combined degeneration, infections like acute disseminated encephalomyelitis and HIV encephalitis, Creutzfeldt-Jacobs encephalitis, uh, toxins like radiation, chemotherapeutic agents, and methanol, hypoxic ischemic etiologies like vasculitis, Charcot-Marie-Tooth disease, and copper deficiency. Now, peripheral nervous system diseases could include dry beriberi, Guillain-Barré syndrome, vitamin B12 deficiency, OP poisoning, chronic inflammatory demyelinating polyneuropathy. Now, let's get back to MS and understand the pathophysiology of this disease. So, there are genetic and environmental risk factors that will lead to immune activation. So, in genetic factors, HLA and interleukin receptors are important, and monozygotic twins has a concordance of 30%. Now, in environmental factors, a very controversial vitamin D levels are important because of its immunomodulation effect. Now, when these factors will cause immune activation, certain things will happen, like peripheral activation of autoreactive CD4 cells, particularly uh, the Th1 and Th17 will occur, that will be against myelin antigens, that are myelin binding proteins. Followed by this, these will attack the blood brain barrier. Uh, that is when the activated T cells will cross the blood brain barrier and secrete the pro inflammatory cytokines, which are INF gamma and interleukin 17, which further will increase the permeability. This will lead to the inflammation of central nervous system and recruitment of other immune cells like B cells, which acts against the myelin oligodendrocytic glycoprotein and other cells like macrophages and microglial cells. This will lead to local activation of immune responses. Now, with all these in hand, demyelination will set in. That will cause that will be caused by attack of oligodendrocytes, and that will be caused by attack on oligodendrocytes and myelin sheath. This leads to activation of repair mechanisms and formation of plaques by uh, gliosis and formation of white matter lesions. Mainly in the periventricular area, which is also one of the important features that will be seen in investigations when we do the MRI. Then the most pathognomonic feature of this disease is axonal damage, which when happens leads to chronic inflammation and irreversible neuronal loss. With all these in hand, clinical manifestations will set in. So let us look at the clinical manifestations of this disease. So before we start with the clinical manifestations, a very important and interesting phenomenon should be looked at, uh, in which the patient will say that whenever they take a hot bath or after intense activity, they feel that the symptoms have worsened. So what happens is this is called the Woodhoff's phenomenon, where the temporary worsening of neurological symptoms in people suffering with MS and other demyelinating diseases when the body temperature rises. Now let us look at the different manifestations of this disease. So sensory symptoms and optic neuritis are the most common, with a 37% incidence according to Harrison. Now, sensory symptoms could include tingling or pins and needles, formication, painful burning, that could be paresthesia. Then reduced sensation or numbness, dead feeling as hyposthesia, unpleasant sensations like sensation of swelling, wetness, rawness, or tight wrapping, and a very characteristic sensory level which could indicate spinal involvement, often with band-like torso-tightness. Now, pain, which is generalized, is experienced by more than 50% of the people with MS, is characteristically migrating. That means one day the patient will say that they're having hand pain in the hand, and the other day they'll say that they're having pain in the ear. Now, optic neuritis, which is again very characteristic, includes visual disturbances and color desaturation, which is a phenomenon where the patient will have color blindness in certain visual fields. Parallel to it, like as in scotoma, where the patient complains that they are not able to see in few visual fields, the patient might say that they are having color loss in central vision. So this phenomenon is called as color desaturation. Now, other features like diminished visual acuity or dimness, then periorbital pain, which worsens on eye movements. Clinical signs could also be elicited like afferent pupillary defects, papillitis, then optic atrophy. Now, if uveitis is present, MS should not be included because then it suggests of alternative diagnosis, mostly like sarcoidosis or lymphoma. Motor weaknesses uh, could be like loss of strength, fatigue, impaired gait, exercise induced worsening, and the patient will be so tired that they say that even carrying out the activities of daily life are impossible for them. Now, upper motor signs like spasticity, hyperreflexia, Babinski's sign, and cramps could be present, while lower motor neuron signs will also be present, like reflex loss and so this disease is very unique as it shows both upper motor neuron and lower motor neuron signs together. Facial weakness would be like Bell's palsy, but apart from it, there will be no loss of taste or retroauricular pain. Now, spasticity or muscle stiffness would be experienced by more than 30% of the population with MS and may impair ambulation or self care. The visual disturbances would include diplopia, which resolves on eye closures due to INO or internuclear ophthalmoplegia, or cranial nerve 6 palsy, or rarely 3 or 4. Now, internuclear ophthalmoplegia is a condition which is classic and often highly associated with ocular manifestation of MS, especially when bilateral. So it is often bilateral because demyelination occurs in both medial longitudinal fasciculars. So when said that it is a condition that arises from a lesion in medial longitudinal fasciculars, which is a brain stem tract essential for coordinating eye movements. About medial longitudinal fasciculus, it connects the abducens nucleus, which is the nucleus of cranial nerve 6, of one side to the oculomotor nucleus of the opposite side. So it coordinates the horizontal conjugate gaze, thus ensuring both eyes move together. Clinical features when INO happens is ipsilateral impaired adduction. That means the side where the lesion is, the adduction will be impaired, and contralateral abducting nystagmus, which is jerky lateral movements due to unopposed lateral rectus activities. Both eyes will have convergence intact since this condition since convergence does not include MLF. So the patient might say that they're having uh, horizontal diplopia, especially when looking to the sides, difficulty tracking moving objects, or feeling of eyes not moving together. Signs like inability to adduct or the affected eye during lateral gaze, nystagmus in abducting eye, and no convergence impairment helps distinguish INO from other causes of eye movement dysfunction. So you can remember INO with ipsilateral no over, that means there's no adduction in the eye which is having the lesion. Now, other features of MS related INO that may occur with other gaze disorders are horizontal gaze palsy, 1.5 syndrome, where INO with gaze palsy occurring on the same side, and pendular nystagmus. An MRI may be required to check for the demyelinating plaques in the brainstem. The other symptoms uh, include ataxia, which could be of cerebellar dysfunction. Thus, cerebellar dysarthria, scanning speech, and limb ataxia could be present. Vertigo with brainstem lesions could be sudden in onset and mimic acute labyrinthitis could be there, and hearing loss could be present, but it is rare. Now let's move on to the other symptoms that could be associated with demyelinating conditions like Lemmerite syndrome, which be tingling of spine or limbs on neck flexion, progressive non-compressive paresthesias, paraparesis, partial Brown-Sequard syndrome, internuclear ophthalmoplegia with ataxia, and postural rubral Ohm's tremor, then trigeminal neuralgia, uh, and recurrent facial palsies. Now, facial myokemia and bladder involvement could also be there. The bladder involvement would could be arising from hyperreflexia of detrusor muscle, which would lead to incontinence. That means when the bladder is filled, the detrusor muscle will keep on contracting, thus leading to incontinence. And sphincter dysenergia, which is the sphincter will fail to relax, leading to urine retention. Now let us see the progression of this disease. So the clinical course of MS could be termed as relapsing or remitting MS, which is the most common type, where discrete attacks will be seen with complete recovery. That means the patient will be having the baseline. Or secondary progressive, which is after the relapsing remitting type, the patient will have increase in symptoms that could decrease and increase, but it never goes back to the baseline. Then primary progressive, which is only 10 to 15% of the cases where the symptoms will increase from the beginning itself and will never come to the baseline. Then there's progressive relapsing MS and malignant MS or aggressive MS, where the disease with a very rapid progression course leading to significant disability and multiple neurologic symptoms in a relatively short time after the disease onset. Tumefactive MS acts like a tumor-like MS variant in which some patients with demyelinating disease presents with a large, more than 2 centimeter acute lesion, often associated with edema or ring enhancement. Let's talk about the expanded disability status scale, which is to scale the disability that the patient is having, where 10 is death due to MS and 1 is no normal neurological examination, that is functional status is normal. Now, a score of 9.5 is when the patient is totally helpless and bedridden and unable to communicate or eat. Now, 9 is a patient who's bedridden but can communicate and eat. 8 is essentially restricted to bed or chair or perambulated in wheelchair but out of the bed most of the day and retains many self-care functions, generally has effective use of arms. 6.5 is they need constant bilateral assistance to walk about 10 meters without resting. Score of 5 is ambulatory without aid or rest for more than 200 meters. And this scale is very important to see what treatment that the patient might require. Let's continue with the investigations and management in the other part.